Good afternoon. Am I audible to everyone? So today's masterclass, the first session, we'll be conducting it from the PICU team of SRCC Children's Hospital. We are going to present a very interesting case which came to us as a very significant diagnostic dilemma. We had to rack a lot of our brains to try to come to a conclusion as to what we are dealing with. And we would present this case. It is like a cautionary tale. Once we come to the completion of this case, we will realize that it's a cautionary tale for all of us practitioners, especially pediatricians, who deal with a lot of medications that we prescribe to our kids. So without giving anything further away, I would hand over to Dr. Avina, who is our PICU fellow, who will come from here and present the case. And after she has presented the case, the topic will be discussed by Dr. Karan, who is also a part of our PICU team. So Dr. Avina and Dr. Karan will discuss the case and the theoretical aspects of the case that we are going to deal with. So I'll hand over and I'll share the slides now. Okay, so it will be Dr. Avina taking over now.
Good afternoon, everyone. I'm Dr. Avina Pokharna, PICU Fellow at SRCC Children's Hospital. And I'm presenting this under the guidance of Dr. Ayon Sen Gupta, Senior Consultant, Critical Care, SRCC Children's Hospital. Sorry. I request everyone to mute, please. So a 3.5-year-old boy was transferred from Noor Hospital to SRCC on 8th of November with the complaints of cough, coryza since 8 to 9 days, fever since 4 days, decreased oral intake since 3 days, fast breathing since 3 days, and not passed urine since 2 days. When he arrived at our ER, he was drowsy, afebrile, tachycardia was there, and he was tachypneic. He was hypertensive with blood pressure of 135/85. He was maintaining 100% saturation at room air, but the pupils were bilaterally 4 mm dilated and non-reactive to light. His GCS was 14/15. Initial investigations on the admission were as follows. We did a arterial blood gas, which showed high anion gap metabolic acidosis. The anion gap was 23.7, which was very high. The pH was 7.17 with bicarb of 7.3. Electrolytes on the blood gas showed severe hyperkalemia with potassium of 6.7, and there was severe base excess of 19.9. Further investigations, the B of 9.9 with mild leukocytosis, but the CRP was raised, which was 53. Renal function test showed a very elevated serum creatinine of 8.6, BUN was 160, and further electrolytes showed hyperkalemia with potassium of 7.3. The liver function test showed raised liver enzymes with SGPT of 960, SGOT of 733, and phosphate was very high, which was 11.7. So the overall clinical picture pointed towards that the child was in AKI. So we did a USG KUB, which showed very hyperechogenic kidneys. The kidneys were lightening up, but there was no evidence of obstructive pathology on the USG, which pointed towards medical renal disease. Also, the USG revealed that there was some sort of crystal deposition that had precipitated in the pelvic calyceal system. So on the basis of the above clinical history and the findings, the child had multi-system involvement as the liver enzymes were raised. Also, the child was encephalopathic and the renal function tests were deranged. He was an AKI. So on further history review, there was a history of second-degree consanguineous marriage, and the differential diagnosis of oxalosis was kept as there was some crystal deposition seen on the USG. However, coma and liver dysfunction could not be explained, but acquired oxalosis resulting from the ingestion of a substance like methanol or ethylene glycol was a complete fit to the clinical picture. So further course in the PICU was as follows. As the child was in AKI, we had started peritoneal dialysis for him, and GCS at the beginning of the treatment was 13/15. So his initial, when we started the peritoneal dialysis at 3 p.m., his serum potassium was 7.3 and bicarbonate was 7. After 6 hours of peritoneal dialysis, the serum potassium had decreased from 7.3 to 5.7, and there was an improvement in the bicarb from 7 to 14.7. Further dialysis was continued, but on the second day of admission, there was CO2 retention and the child was hypoventilating. So we started him on NIV support. His GCS at that time was maintained as on admission of 13/15. Further, the labs on the subsequent days showed decreasing potassium with improving acidosis, but the urine output was still 0 after 2 cycles of dialysis. On day 3, he became stuporous. There was severe hypoventilation and the pupils were bilaterally 2 mm, non-reactive. He was severely encephalopathic. There was no Doll's eye response. So he was intubated and started on mechanical ventilation. And dialysis was continued. As he had no sign, so at that time the corneal reflex was absent. There was no Doll's eye response. So we did an EEG which showed diffuse but posteriorly dominant slowing, which was suggestive of mild cerebral dysfunction, non-specific for any particular etiology. MRI brain was done, but so we did an MRI brain to see for any cerebral edema leading to that encephalopathic state, but there was no significant brain parenchymal abnormality. No edema was found. No abnormality was seen on the MRS, but there was an incidental finding of Chiari-1 malformation with peg-shaped cerebellar tonsillar herniation with mild central cord hyperintensity, which was not contributory to the present condition. So we went for an ophthalmological evaluation, which showed hyperrefringent particles in the retina, which was correlating with the brightening kidneys that was seen on the USG. So the USG was suggestive of some sort of deposition, which had led to the brightening. And even on the fundus examination, we had seen hyperrefringent particles. So the diagnostic dilemma that we were presented with was the child had presented to us with an acute onset multi-organ dysfunction. So this was an absolutely normal child with an acute history of 7 to 9 days of mild cough, cold, and fever, and he had presented with AKI, whether anuria and severe hyperkalemia, hyperphosphatemia. Also, the liver enzymes were raised, and he was severely encephalopathic. The child had progressed to deep coma. He presented to us with GCS of 13/15, and he had progressed to 3/15 within a span of 48 hours. So the positive pointers for some accidental substance ingestion here was there was highly echogenic bright kidney. There were hyperrefringent particles in the retina, which both of these were suggestive of some possibility of some kind of deposits. As there have been reports of cough syrup contamination by ethylene glycol, and he had received cough syrup of the following brands, which were Ace Total Cold by Johnson and Smith and Liturgic Cold, and presented with API with deranged LFT with deteriorating sensorium. Ethylene glycol toxicity was suspected. The pointers towards ethylene glycol toxicity in this whole case scenario was the child had renal failure, he had multi-organ dysfunction, and he was comatose. So all the clinical picture fit into the ethylene glycol toxicity. So our further diagnostic evaluation was pointed towards the ethylene glycol toxicity. Further course in the PICU, the corneal reflex was absent. There was no doll's eye response. In view of the following signs of brainstem death, apnea test was done, which was positive. The PCO2 had raised up to 96 from the 46 before the start of apnea test. EEG, serial EEGs were done during the course of treatment, which showed slowing of activity. Dialysis was continued, keeping in mind the possibility of DEG toxicity to eliminate the toxins from the system. As we were suspecting this accidental ingestion of this toxic substance, so medico-legal reporting was done and cough syrup samples were sent for analysis. So the child had a history of taking 2 cough syrups and 1 unknown medication for fever. So our evaluation ethylene glycol, when it is ingested in the body, it gets converted to glycolic acid and oxalic acid. So we went for serum oxalate levels evaluation, which was very high, 17.4. As we can see in this table, the normal value should be less than 3. 24 hours urine oxalate was sent, which came to the value came around 18. Further, because of the encephalopathic state had continued in this child, there was absolutely no neurological improvement. CSF examination was done, which showed cells of 81 with neutrophils of 40%, protein of 95, and sugar of 107. To rule out any infectious cause for this encephalopathic state, the cultures and PCR were sent, which were negative. And as we were suspecting ethylene glycol toxicity, one of the byproduct that we get after the metabolism is glycine. So we went for plasma as well as CSF glycine levels. So CSF glycine levels were very high. The normal range should be less than 8.3. In our case, it was 102. Also, the CSF plasma glycine ratio was very high, which was 0.7. The normal value, even if we suspect in a child who has hyperglycemia, it should be less than 0.04. But in our case, it was 0.7. Renal biopsy was done, which showed tubular injury, and there were few calcific and hemorrhagic material that was seen in the tubules. Electron microscopy also was suggestive of severe tubular injury. So as the days progressed, after 5 cycles of hemodialysis, our child had passed urine. So we could do a urine examination, which revealed glycosuria, proteinuria. There was presence of ketone bodies, but oxalate crystals were not seen. And so the 24 hours urine oxalate was sent, which showed a value of 18, which was normal. As there were, there was absolutely no neurological improvement, and pupils were fixed and dilated. MRI, we repeated an MRI brain to see for any evidence of cerebral edema, but there was no evidence of cerebral edema even on the second MRI. And as compared to the previous MRI, it had shown cerebral atrophy. The pupils continued to be fixed and dilated, and the GCS continued to be E1, VT, M1. Child was passing adequate urine. the samples that we had, the cough syrup samples that we had sent for evaluation, finally the report came and it showed a peak in the diethylene glycol levels, confirming the presence of excessive diethylene glycol in the cough syrup. So as we can see in the graph, the diethylene glycol level shows a very high peak, whereas the normal solvent, that is the normal solvent in cough syrup, which should be glycerin, is showing a very low peak. So this chromatography report hence proved a diagnosis of diethylene glycol toxicity. Neurologically, the child did not show any improvement. Serial EEGs done every day showed reduction in cerebral activity over both the hemispheres and intermittent delta activity. As the child was not showing any kind of improvement, the ethics committee were involved regarding the continuation of the treatment in such case, but the child finally expired. So even after multiple cycles of dialysis, the child continued to be encephalopathic, although his renal function was improving, but the encephalopathic part did not improve.
So, to continue further the discussion on this topic, we will be now discussing the theory behind it, and this will be done by Dr. Karan. So I'll just share the slides again. Yeah, so I'll hand over to Dr. Karan now.
Good afternoon, everyone. I am Dr. Karan. I am a PICU Clinical Associate at SRCC Children's Hospital. So I'll be discussing the theoretical part of the case which we have just discussed. To begin with, since 1990, we have seen several mass poisoning which has occurred due to toxic cough syrup in developing countries. What happens is the glycerol, which is a costlier solvent, is replaced with a relatively cheaper alternative, which is diethyl glycol. This diethylene glycol is a nephrotoxic drug, and it causes MODS, like multiple organ dysfunction, especially in children. We have seen several reports from Panama, China, Hatay, Bangladesh, Argentina, Nigeria, India, and Gambia between 1992 to 2022 due to these toxic cough syrups. So what is ethylene glycol? It is a colorless, odorless, sweet-tasting liquid. It is usually used as an antifreeze, hydraulic brake fluids, some stamp and inks, ballpoint pens, solvent, and other cosmetics. So the toxicity can be accidental addition of the this drug, or it can be suicidal attempts like an antifreeze agent. Most ethylene glycol poisoning occur due to ingestion of antifreeze. Pharmacology behind this is the parent alcohol. Ethylene glycol, it is relatively non-toxic. It only causes sedation like normal alcohol. The toxicity, profound toxicity, occurs due to its metabolite, which are glycolic acid, oxalic acid, and glycine. The peak toxic levels are like more than 20 mg per dl, can cause end organ damage, which in millimoles comes to 3 millimole per liter of ethylene glycol. Metabolism, like alcohol is like alcohol, ethylene glycol is also metabolized with alcohol dehydrogenase, which is converted into glycoaldehyde. Further, aldehyde dehydrogenase is converted into glycolic acid, which is further converted into glycoxylic acid, oxalic acid, and glycine. These metabolites, glycolic acid, oxalic acid, and glycine, are much more toxic than ethylene glycol. So kinetics of this ethylene glycol, it is very rapidly absorbed once it is taken orally. The absorption is almost 100%. Peak serum concentration reached within 1 hour of ingestion. Only 20% is excreted unmetabolized in the urine. and it follows 4 pseudokinetics. An estimated half-life is 3 to 9 hours. So this is the pathway. After oral ingestion, it gets rapidly absorbed in the intestine. As soon as it is absorbed, the plasma ethylene glycol level and osmolar gap both increases rapidly. As soon as it is absorbed from the blood, it goes into the liver. Liver, it is metabolized again like aldehyde, glycolic acid, glycoxylic acid, and oxalic acid. As it goes and get metabolized in the liver, the plasma ethylene glycol level start decreasing, osmolar gap start decreasing, but the anion gap, because of this glycolic acid and oxalic acid and this lactate, it keeps on increasing. Further, this oxalic acid gets converted into calcium oxalate in the kidney and causes tubular precipitation, leading to hyperoxaluria and crystalluria. So this down bottom, this is showing. What happens is the measurement of ethylene glycol is very difficult. No, not many laboratories measures ethylene glycol level. So to get the surrogate marker, there is a gap called lactate gap, which we can measure. So the measurement of the lactate can be done in 2 ways, by a oxidase method and lactate dehydrogenase method. The oxidase method is utilized when we send a ABG during our point of care estimation. That ABG utilizes oxidase method, and it also counts the glycolic acid, glycolate, as lactate. And the true lactate is measured with lactate dehydrogenase method. So if we find a huge gap between oxidase lactate from the oxidase method and lactate from the lactate dehydrogenase method, so that delta lactate is too high, that suggests there is something which can be added to the true lactate, like glycolic acid. So it can be used as a surrogate marker. So stages of progression of glycolic acid, ethylene glycol toxicity. For it is in the 3 stages. First stage is first 12 hours. In this, unmetabolized ethylene glycol causes CNS depression, hyperosmolarity, and intoxication similar to ethanol. Within first 48 hours, from 12 hours to 48 hours, this glycolic acid is generated, which causes severe acidosis and compensatory hyperventilation. And then increased lactate, calcium oxalate crystals start depositing in the organs like brain, kidneys, lungs, and heart. And last, within 72 hours, there is direct cytotoxic effect of glycolic acid causing acute renal failure. If we go organ-wise, CNS unmetabolized ethylene glycol causing depression, dizziness, ataxia, disorientation, irritation, everything. In severe poisoning, coma and death can occur. And the last is cerebral edema due to the deposition of the calcium oxalate crystal in the wall of the small blood vessel can occur. Renal-wise, acute tubular necrosis, renal failure within 24 to 28 hours. Calcium oxalate crystals in the renal tubules causing tubular necrosis, and focal tubular degeneration can also occur. Acute oligouric renal failure and necessitate hemodialysis. Metabolic wise, we have seen plasma osmolarity increases and iron gap increases, hypocalcemia and tetany can occur. Respiratory wise, central CNS depression, acidosis, and aspiration of this secondary may cause pulmonary edema. Very few side effects on GI and dermal and CVS. Evaluation wise, as we have seen, we will check for the to rule out other poisoning. We can check for blood levels of salicylate, acetaminophen. ECG in advanced ethylene glycol poisoning may show QTc prolongation. ABG to know about an iron gap. RFT and electrolytes to know the status of the kidney and hypocalcemia. Urine examination may show oxalate crystals. Then serum ethanol concentration, osmolality for osmolar gap, and USG, KUB, and MRI. So as we have seen, these 3 gaps we have discussed: osmolar gap, an iron gap, and lactate gap. So this is a graph showing trend of the these three gaps. Initially, the osmolar gap will increase because of unmetabolized diethylene glycol. As the diethylene glycol start getting metabolized, the level of the osmolar gap start decreasing, and the lactate and anion gaps start increasing. So, depending upon at what time we are collecting the sample, the levels of osmolar gap, anion gap, and lactate gap will be different. And urinary oxalate crystals can be seen, which are of two types: monohydrate crystals and dihydrate crystals. The monohydrate crystals are needle shaped and can be misinterpreted as burette crystals, and dihydrate crystals are envelope shaped. These are the photographs showing monohydrate and dihydrate crystals. These are the envelope shaped crystals. And coming on to the treatment, first basic management for all the patients, like we do in PICU, air circulation. After managing airway breathing and circulation, if you're sure or we have a doubt about ethylene glycol poisoning, we may use omeprazole, which is used in 15 mg per kg IV loading, followed by 10 mg per kg 12 hourly for 4 doses. If omeprazole is unavailable, we can use ethanol, 10 ml per kg of 10% ethanol solution, followed by 1 ml per kg of 10% ethanol solution infused per hour. But difficulty in using ethanol is to titrate the serum ethanol concentration. We have to measure repeatedly the serum ethanol concentration. To compensate the acidosis, we can also use sodium bicarbonate at 0.22 mg per kg. And then other drugs like thiamine and pyridoxine, they bypass this metabolism of ethylene glycol to other cycles, and they are given in a dose of 100 mg IV to pyridoxine of 50 mg IV. If the diagnosis is uncertain but the clinical suspicion is high, we should be initiating the antiviral treatment. And the best modality of treatment, if nothing can be done, hemodialysis is the last resort of the choice. So after discussing the case and the theoretical part behind this, we have a message for everyone that if any patient is landing up in emergency with sudden onset and anuria, deterioration in sensorium, blood gas showing elevated blood lactate, and there is high anion gap metabolic acidosis, we should always be having a possibility of poisoning in our mind as a differential diagnosis. And if there is a use, and we should all be trying to avoid unnecessary usage of these cough syrups. That's it from my side. Thank you.
So that was what we wanted to present from our end today. As I said at the starting of the talk, that it is a cautionary tale of sorts. Unmitigated use of cough syrups in children, which are very rampantly prescribed, can sometimes, unfortunately, lead to conditions which we do not want to encounter at all ever. So with that, we would end our presentation. Happy to take any questions from any of the participants. There is no specific cough syrup or brand that we can mention over here. There's a question which cough syrup specifically to avoid. These chemicals are present in all of the cough syrups. It depends on what quality the manufacturer is using. So if they go for substandard material, we can come across these events happening because of ingestion of things which should not be there in the cough syrup. So it is not every cough syrup will contain ethylene as a chemical in it. So if they're using the normal stuff, it should not happen. If they go for the cheap substandard stuff, they will replace it with ethylene glycol, which will be the substance which should not be present, and it can lead to problems. no general safe dose to be prescribed. Frankly, if you go through literature, cough syrups are no better than placebos. So if you have a child who needs a bronchodilator, please prescribe bronchodilators. If you need a child who has an allergic, you prescribe an anti-allergic. But in India, we have multitudes of cough syrup which have multiple items in it. There'll be an anti-allergic, there'll be a soothing agent, there'll be a bronchodilator, there'll be a paracetamol in it. So 3, 4, 5 combination cough syrups are available in India. I don't think it is available anywhere else, the kind of stuff that we prescribe around. So that is the problem. There is no safe number to prescribe. There is no safe dose to prescribe. If you are prescribing a bronchodilator, please prescribe a simple salbutamol syrup, which does not contain anything else. Or please prescribe something like a cetirizine or chlorpheniramine maleate or a phenargan, which contains nothing beyond the promethazine. So those are the kind of drugs which we can still prescribe safely because they are from standard brands having single components. Once we go into multiple components and polytherapy, then the problems set in more. Mucolytics if required, yes, but do we really need to give mucolytics to all our kids? I strongly doubt that. They are no better than placebos, frankly, a mucolytic. Any other questions? Then why only there's a question, why only very few children go into encephalopathy? Giving a cough syrup will not lead to encephalopathy. The cough syrup doesn't cause the encephalopathy. The encephalopathy is because of the toxins present in the cough syrup. These toxins should not be present. Now, if the manufacturer is using substandard material or not using the proper processes to manufacture the cough syrup, then you will end up with an increased amount of these components like diethylene glycol, which should not be present in the cough syrup. And once the diethylene glycol enters the system, it gives rise to toxic metabolites, which leads to encephalopathy. If the cough syrup does not contain the product, it will not lead to encephalopathy. So the cough syrup that this child unfortunately took, and as we proved by doing the chromatography on the cough syrup, had a very high content of diethylene glycol, which should not be otherwise present in the cough syrup. Now, we are not testing these cough syrup for toxins and contaminants routinely. We do not know which cough syrup contains which contaminant, or if at all it is there. So it will be a one-off, but even that one-off can kill a child. This is the thing that we want to put across, that even one child taking a cough syrup, which like we had in Gambia recently, 100 or 150 children died. We had a recent event again when another manufacturer in UP or Delhi somewhere was supplying to some place in Europe and children died. So it depends on whether you are using a cough syrup which is contaminated or which is containing the toxin or producing element or not. Not every child will land up with this, but some may, and it may be fatal in those who land up with this. May someone type the name of the cough syrup? Is it? So diethyl glycol is a contaminant in the cough syrup which should not be present. It is part of every cough syrup has got alcohol in it. So normally they use ethanol, but sometimes they use substitutes like this. So diethylene glycol will never be there as a component of the cough syrup. You will never find it in the list, but it is a contamination in the cough syrup, which if ingested can lead to toxicity and death. So there is no name of cough syrup containing diethylene glycol. Any cough syrup can have it. The toxin in diethylene glycol can give rise to toxic metabolites within the body, which can lead to acute tubular necrosis, retinopathy, encephalopathy, and acute liver failure and death. You can use a plain dextromethorphan if you want, or just don't give anything. The child will tide over it. You do not need to prescribe a cough syrup for every cough. That is what we are trying to put across right now. Safe age to prescribe cough syrup. There is no safe age. The antihistaminics mostly like something like fexofenadine can be given beyond 6 years of age. If we look at the other antihistamines like promethazine or chlorpromazine or chlorpheniramine maleate, they are all for more than 2 years of age. But we are prescribing the same cough syrups to 1 month, 2 month, 3-month-old children. Role of Ayurvedic cough syrup. Frankly, I have no answer to that because I am not aware of, or I'm not knowledgeable about Ayurvedic cough syrups. Sorry. This child received a cough syrup named Ace Cold Total. That was the one which had the diethylene glycol in a very high volume in it. You can give nasal decongestants. You can give some steam inhalation in a child. You can give antihistaminics if it is needed. Shall we then end this session? Okay. So I would like to hand over this to the next speaker, who is Dr. Prashant Patil, Senior Pediatric Endocrinologist from SRCC Children's Hospital, who is going to speak on precocious puberty today. Dr. Prashant, are you around? Okay, another question has come in. Diethylene glycol will never be mentioned as a content because it is not a part of the content. It is a contaminant which should not be there. You will never find them in the list of contents in the cough syrup. Is Dr. Prashant around? A bit of interruption over here. Dr. Prashant Patil, our next speaker, will join in the next 5 minutes, and we'll take it from there. Just be patient, and we'll just have to wait it out for the next 5 minutes or so till he joins the
Hello. Yeah. Am I audible? All right. So very good afternoon to one and all. At the outset, I would like to thank uh, SRCC Masterclass organizing this opportunity. In next 40 to 45 minutes, we will look into the important topic like how one should approach a precocious puberty in girls. Girls more so because it's far more common in girls. And with the onset of epidemic, we are seeing more and more numbers of girls who are coming to us with early puberty. So what I'm going to do is I'm going to show you three cases rather explaining the different scenarios in terms of precocious puberty and how important is the management. And once we start the management, how do we and why it is important that we investigate them early and start the treatment early for their final statural outcome. So this is the first case. This 9.5-year-old girl, she got her menses at 6 months back. So she was almost 9 years. So as usual, she went to the gynecologist. Gynecologist told that there's no need to panic because nowadays most of the girls, they mature early. So she has just reassured. However, after 3 to 4 months, because initially the periods were irregular, but her flow was too much, so she couldn't manage the menstrual hygiene. And for that, she has missed her school also for next 4 to 5 days. On examination, she was 28 kg. Her height was 128 centimeters, so maybe 4 feet and just a couple of inches. As per the mother's and father's height, her mid-parental height, that is final adult height, was supposed to be 156 centimeter plus minus 5 centimeter. When we dig the history, she was born as a premature child with a birth weight of 1.1 kg. So she was small for gestational age. When we did her bone age was 13 years and 6 months. So as you can 9.8 year, the bone age was quite significantly advanced. So any difference than 1.5 to 2 years from your chronological age versus bone age is significant. So here is a case of 9 year and 9.5 year where her bone age is almost advanced by her evaluations, which we did like LHFSH and estradiol, they were quite pubertal, which was indicative of central precocious puberty. Even her sonography was suggestive of pubertal changes in the uterus and the ovaries. So the diagnosis was quite obvious. She was having a central precocious puberty. Now, what is one thing that we can offer, as we know that we generally start them on a LHRH or a GnRH analog, that is leupride acetate. She was started on 11.25 12 weekly, and we could continue this treatment for another 1.5 year till she attains the psychosocial or maturity to handle the menstrual hygiene. But whenever we treat such kids, especially nowadays when there's a lot of precocious puberty coming to us, we are not so treating such individual, because the first and foremost thing that her height is compromised forever. Even if we treat her with a GnRH analog, she's gained too much of height. The reason being her bone age is almost more than 12 and a half. So the moment your bone age is more than or 12 and a half years, your final height is more or less achieved. So here we are treating the child just for her psychosocial maturity. So maybe by we are just dragging, so that dragging for 1.5 years, so that at 11 years of age she may handle the menstrual hygiene properly. But it's a loss. We couldn't offer her a final adult height, as we can see from the previous slide that her final height potential was 156 centimeter, whereas she will probably end up maybe somewhere in 30 centimeter. So this is what a precocious puberty is all about. It is very important that they get diagnosed even before they start menstruation. And we will see how it is important and how are the stages of puberty. Puberty is nothing but a stage of human development where a sexual maturation, physical growth are completed. So the second part of a definition of puberty is important, that is physical growth. So we often forget about the second part, physical growth. We kind of puberty, we just generally take into consideration only in terms of sexual maturity, but physical growth is also equally important. So the puberty is a complex event. It is associated with multiple chain of sequence with hormonal and
गाड़ी बेची भाई 100 से 272 कार 24 1 एक जन 180 ને 170 का भाई एक जन 180 હું પાછો ફોન ગયો મારે મિસ્ટેક થઈ 180 નો કોટ થયો 272 સારું કહેવાય કાર 24 આપણે ગ્રીસ જોતી ને લોકો ને બે ને 10 20 આવે બે 35 આવે છે ને બે 10 20 રે પાવેનો હતો આ.
So normal puberties consist of three sequences, that is hierarchy, pubarchy, and menarche. The breast development start roughly at around 9 or 8 to 13 years, and there are 2 to 3 stages. You can see the height spurt. The height spurts happen between third and fourth stage, whereas menarche happens at the fourth stage of puberty. And this is how the sequence of puberty is. So if you go back in our first case, she was already at a menarche. That means she has crossed this height spurt. And that is what I was emphasizing into, that unless we treat them early, maybe between breast stage second and breast stage third, or maybe before B, we can offer them a good height potential with the help of treatment by prolonging the puberty. However, if they are coming to us between fourth and fifth, we can't do much about it, especially in terms of final height. So her height remains compromised. So puberty is a set of events, and it is predominantly based on early activation of hypothalamic pituitary gonadal axis, or also known as HPG axis. So this HPG axis is active during the embryological age. Even after birth, this is relatively active. So that stage is known as mini puberty. After 1.5 years of age, this HPG axis remains inactive or quiescent for a period of almost next 6 to 8 years. And there are certain genetic factors or stimulant which is important for a pulse generator, which will again activate the HPG axis. Now, what stimulate HPG axis? But there are few genes like kispeptin and its receptor is involved in stimulation of hypothalamic pituitary axis again. So what happens during this stage, that activator, because of the gonadotropin secretion, it increases the sex steroid, and that is how the puberty starts. So generally, on an average, a boys mature between 9 to 14 years, whereas girls start to maturing between 8 years to 13 years. So this is the when we compare a normal population almost 95 to 96% of the cases are between this age group. So anything which is happening before this particular age group, that we define as a central precocious puberty. So these are the hormonal changes which happen during the precocious puberty, and obviously they precede the physical changes by almost 1 to 2 years. And that is why the blood investigation like LH and FSH, especially the LH, is far more important, that even before a girl show a breast development or a significant breast development, you can know from the blood test it's maturing faster. Along with HPG axis, it leads to gradual activation of GnRH, which will increase the amplitude and frequency of LH pulses. Apart from these gonadal changes, there will be somatotropic changes or extragonadal hormonal changes in the form of surge in adrenal steroid of IGF-1, which is important for the pubertal growth spurt. Also, nocturnal LH secretion precedes the phenotypical changes like breast development and pubic hairs. So puberty is associated with not only not only LH pulses, but also associated with increase in the insulin resistance along with elevation in. So in short, it is associated with sex steroid synthesis, which can lead to a sexual maturation. And there are other non-gonadal changes as well, which leads to a somatic growth. So puberty is a combination of sexual maturation along with accelerated somatic growth. Now, we are seeing secular trend towards an early puberty within the Western Europe and USA. In fact, they are through trend. And what has been noticed across the globe, that with every passing decade, there's a gradual decrease in the age of menarche by almost 2 to 3 months. So over a period of time, the age of menarche reduces by almost 2 to 3 months. Age of onset of puberty is a complex physiological process, which is a subject to a correlating factors.
Could switch off the audio. Last one.
Oh.
I'm sorry.
Anabis. Anabis. Imara Sanjay Nagar Marabis. Marabis.
Can the person who has switched on the audio please switch it off?
Okay. So one of the important factors which has been contributed in the onset of precocious puberty is considered to be obesity, that is nutrition and overnutrition. And one cannot agree more that during pandemic years that everyone has gone into that obese and overweight spectrum, which has led to a development of precocious puberty. I'm going to show you those interesting papers is where the average age of menarche in a Western population on the left-hand side and some of the trends in South Asian countries like Korea on the right-hand side. So on your left-hand side, on x-axis, you can see the years, that is 1830 to 1990. And on the y-axis, you have age of menarche. So if you see the brown worm, that is for US, in 1900, the age of menarche was 14 and 14 and a half, whereas in 1990, it has gone down to 11.5. So that is how significant this reduction in the age of menarche. Whereas if you see the Korean chart, we are not far behind. They are already through this secular trend. But if you compare the Asian population, especially in the Korean girls, you can see similar kind of thing happening in the Korea. So from 1900, the age of onset of menarche was 2 years. It has gone down by almost 1 year. On the right-hand side, it is also seen that those individuals or those girls who were overweight and obese, which has been highlighted by a red worm and a yellow worm, they tend to get maturity pretty early. This again highlights that because of the obesity, the GnRH pulse regulations get activated pretty early. And that is the important factor that why we are seeing more and more cases of precocious puberty nowadays, especially after the COVID pandemic. There are multiple papers written about it in last couple of years, with the incidence going very high, 5 to 6 times before the COVID pandemic. And the plausible or the important mechanism, obviously, the sedentary life makes us obese, increased screen time, few of the chemical endocrine disruptors, which leads to hypomethylation, has also been postulated as a causative factor for precocious puberty and altered sleeping pattern. So those individuals who are have a more, they have altered sleeping pattern and they are awake for most of the night, they tend to develop that early puberty, which is what the plausible mechanisms are. Although these are not a one-on-one cause, these are having a multifactorial association. Recently, the gene and its receptor has been formed, that is kisspeptin and its receptor, which leads to an activation of GnRH pulse regulator, which normally gets activated at 9 to 10 years. But because of the mutation in that particular gene, that is kisspeptin and its receptor, those individuals, who they are not even obese, they tend to develop precocious puberty. And which is why, even if you're seeing a normal girl, which is not so or obese, they have an early onset of puberty. There are certain genetic factors also. So we often ask the maternal age of onset, because if you have a previous history or a family history where mother has started early puberty, then you tend to develop early puberty in a next generation, especially in female. So what is precocious puberty? Basically, whenever you have a bilateral breast development, bilateral breast development before 8 years of age, that is B2, then it classifies as a precocious puberty. In cases of boys, it is relatively difficult to measure the testicular volume, but any testicular volume which is more than 4 ml, then it classifies as a precocious puberty in boys. One second, I think I'm on. And any vaginal bleeding which is starting before 10 years, that classifies as a precocious puberty. So you can remember as 8, 9, and 10, especially in girls, it is 8 and 10. So breast development before 8 years and vaginal bleeding or a menstrual bleeding before 10 years classifies as a precocious puberty. Whereas in boys, if testicular volume is more than 4 ml before 9 years of age, that is as a precocious puberty. So there are 3 types of precocious puberty basically. First and more common is a central precocious puberty, which is also known as true precocious puberty or GnRH dependent precocious puberty, where the HPG activated early and the sequence of pubertal events are normally maintained. That means the Theralk will be followed by Pubark, followed by Menarche. So this sequence will be maintained. That is a central precocious puberty. Where the sequence is non-maintained or there's isolated part of development, this is known as GnRH independent precocious puberty or a peripheral precocious puberty, where the activating signals are not coming from the pituitary, but it is coming from the gonadal region. So it is known as pseudo-precocious puberty, where there may not be a normal sense of puberty. The third is mixed, where generally it is seen in cases of congenital adrenal hyperplasia, where the bone age is advanced to begin with their peripheral precocious puberty. And after the treatment,
Dr. Prashant Patil.
yeah.
May I please pause? I'm so sorry to interrupt.
I know, but I'm,
yeah, but it's just unfair because you are doing such good work. Dr. Ajay, Dr. Ajay, may we please request you to mute yourself? Dr. Ajay, maybe please request you to mute because the entire lecture is going to nothing.
But I think then such participants can be removed from the meeting. I feel it's a waste of everyone's efforts.
Let's take it further. Dr. Ajay, please mute yourself and make sure you're muted.
No, but I don't think he's being able to listen. I
don't
suggest,
think
why
he's
don't we
listening
remove
also.
the person from the meeting?
His audio, video, both are on. Audio, video, both, if you look in the list of participants.
No, but probably, Dr. Nisha, he's put us on mute. He's probably just attending this for the MMC points with all due respect. I think the admin can have the right to then remove. We're all removing time and coming here. All I can hear is some background ranting going on.
So I'm going to mute myself. I'm hoping Dr. Ajay's got the message and he will mute himself. Dr. Prashant, sorry for this, but please carry on.
No problem. Because it's
Dr.
very
Ajay
difficult
is still
to,
not muted though.
He is not
I
muted.
don't
Dr.
think so.
Ajay is
He's
not
listening.
muted.
So I guess what Shruti
Sir,
said is
please hold now.
correct.
The lecture is too good and we don't want to miss it. I'm sorry, but I don't know if the admin is also there around because we are making notes here and we're not able to benefit out of such a good
even
lecture.
I'm not able to tell because even my link is getting disturbed because of
I'm so sorry.
Continuous voice that I
Yeah.
understand. But I saw that if I could mute the gentleman, which is I don't think I have that.
I think the admin should be able to. Maybe Narayana helps. If you all are the host, Dr. Rahul Mishra, you are the co-host. You all should be able to mute or maybe.
All the best, Dr. Prashant.
I need to unmute myself. All right. So I'll just cover the benefit of doubt. You can remember the precocious puberty by simply remembering the three numbers, that is 8, 9, and 10. When we talk about girls, it is 8 and 10. So any breast development which is happening before 8 years, that is precocious, or any vaginal bleeding or a menstrual bleeding which is happening before 10 years, that is also abnormal and qualifies as a precocious puberty. Now, the point which I wanted to make from the first case, that predominantly we are seeing the cases when they are already coming to us with a vaginal bleeding. Really, they should have been picked up at the breast development, because generally from breast development to the vaginal or a menstrual bleeding, you have a period of 1.5 to 2 years, and which is what we want to capitalize on by doing the treatment with the GnRH analog during this particular time, where their bone age is not significantly advanced, like 12 or 13 from the first case. So that is the point. So remember the figure 8 and 10, and if possible, diagnose them as development and not at the vaginal bleeding, because the battle is more or less lost. In cases of boys, it is relatively difficult because you have to have a Pradas orchidometer or years of practice to know the volume. Thankfully, the precocious puberty is not so common in cases of boys. Generally, whenever you are seeing a cases of precocious puberty in boys, more or less it is a pathological rather than idiopathic. The types of precocious puberty, first was central, where the pulses are coming from the pituitary gland, and pituitary is getting activated early, and then the sequence of pubertal event is normally maintained. So there will always be a theralke followed by pubarche, and then there is a menarche. In peripheral precocious, the signal doesn't start from the HPG axis directly. It starts from the gonad. So it is GnRH independent. And since it is a GnRH independent, the normal sequence may not be there. You may find isolated vaginal bleeding, or you may find isolated breast development or something of that sort. So this is classifies to peripheral, or this signifies as a peripheral precocious puberty. And the classic example is your congenital adrenal hyperplasia. It would be a combined variety or a mixed variety, where it is commonly seen in long untreated CAH, where the peripheral precocious puberty, because of the advanced bone age, signals the pituitary. Then again, pituitary starts secreting the LH and FSH. So this is seen in cases of advanced CAH and those who are not been on a treatment. The last part is a variation in pubertal development. Sometimes it could be a normal benign theralge, which is seen between the age of 2 to 4 years, which doesn't need any treatment. Second variation, which is also common in SGA, that is small for gestation, is premature adrenarche, where the adrenal surge is too much. They have a hair development. I'm sure you must have seen in cases of in your own practice. One of the plausible mechanism is that during the intrauterine life, there's not much of a weight gain, and suddenly on top of that, during the extrauterine life, if there is advanced weight gain or sudden weight gain, that is dangerous, which sets in the pubertal hormone secretion, especially from the adrenal gland, and it leads to adrenal surge of DHA, that is dihydroepiandrosterone secretion, and which leads to a hair development, which most of the times doesn't need a treatment. Now, since we have finished the first case, now this is the case which we want to see and love to treat, because they have coming to us pretty early. So this is 7.5-year-old girl born of a non-consanguineous marriage. Mom was smart and she noticed the breast development is since last 6 to 9 months. She has pubic hairs and axillary hairs since last 3 to 6 months. On specific inquiry, she gives a history that during last 1 year, she gained a significant weight and more in terms of height. And initially, she was not among the tallest, but now she is one of the tallest in the class. So this is the first sign. So what is happening here, which I've shown you, that during the third, the spurt happens between the second and third stage of B2 and B3, and the maximum peak happens between the B3 and B4. So she has already got that spurt, which is what is coming in the history, that she has gained in weight as well as height. She is irritable. There are lots of mood changes. And mom classically says that there is increased body odor, which was not there before last 3 to 6 months. On inquiry, there was no history of headache or difficulty in vision, which generally rules out the central precocious puberty, or we have to ask for the CNS symptoms. Birth weight was fine, so she was not an SGA, which has an inherent risk of developing precocious puberty. So on examination, her height was 126 centimeter when she came to me. Her weight was 28.8, which was between 75th to 90th centile on the Indian growth chart. She had mild acne, again classifies, or a classic example or a classic sign of early development. Her SMR staging, she has axillary hair present, so A2, B3 and B4, pubertal stage 3, but M0, no menarche, so M0. On examination, though, there was no goiter, there was no cafeolate spot, there was no previous history of multiple bony fractures. So what we asked her, that we asked for the previous height record. Unfortunately, she didn't have, but her school had mentioned during her annual school record, we get one reading at 5 years of age. So at 5 years, she was 101 centimeter. I'll show you her growth chart. So this is where she was at 5 years of age. And right now she's 126. So she was, as per the mother, she was not amongst the tallest. She was just about, and suddenly in last 1 or 2 years, she has gained in terms of height. So if you're seeing any deviation by more than 2 lines on Indian growth chart, be worried, because either deviation on the either side or either side on the upside or on the downside is significant. You can cross. The cross signifies the bone age. So her bone age was advanced. Her weight was 16.8, and suddenly she has shot up in terms of weight as well. So weight is now 28.8. So she is now on the higher percentiles of Indian IIP growth chart. So on investigation, her bone age was advanced, which is 11.6. Thyroid functions were normal. We did her GnRH stimulation with aqueous leupride. Her estradiol was quite pubertal, 80, that is 80 picogram per ml. Now, the estradiol is generally less than 20 in prepubertal age group. Any value which is more than 20 or 30 classifies that it is a pubertal sample or a pubertal process. Second, the GNR stimulation test remains the gold standard for diagnosis. A single sample of LH and FSH can also be done. If your basal LH is more than 0.3 or 0.4, that indicates that the process of already started. We did this as a gold standard evaluation, and you can see after the stimulation, see the levels of LH and FSH. So LH was 1.4. The stimulation, LH has shot up to 24 and 32 respectively, and 60 minutes. So any changes by more than 2 or 3 times from the basal LH classifies that you are into a central precocious puberty. That means the LH and FSH are overactive, and they are getting stimulated with the help of mini dose of aqueous leupride. So this is nothing but a central precocious puberty. She was started on injection leupride as 0.25 mg with deep intramuscular and injection and 12 monthly depot. So if we see the causes of central precocious puberty, almost 80 to 90% of the cases are idiopathic, maybe more than that. In cases of boys, however, the chances of having an organic cause, that is CNS tumors or CNS dysfunction, is far more common. So in cases of hypothalamic hamartoma, this is the most common CNS tumor which may lead to a central precocious puberty. It is associated with classic seizures known as gelastic seizures. So gelastic seizures, central precocious puberty, and hypothalamic hamartoma, it's a classic triad which may come to you with the precocious puberty. Optic glioma, craniopharyngioma, ganglioneuroma are the common space-occupying lesion which may lead to disruption of pituitary stalk and can lead to a central precocious puberty. In cases of infection, irradiation, trauma, if the child is getting irradiated for acute leukemia, then there is a chance of developing CNS dysfunction and central precocious puberty. So when we see a girl coming to your clinic with early onset of breast development, NRK, then you have to ask for the onset and the progression. If it is very abrupt and acute history, probably you're looking for a tumor or any organic cause, and this is not a central, but it will be a peripheral precocious puberty. Whereas if it is an insidious onset slowly over a period of 6 months to 1 year, more or less, this is a central precocious puberty. Again, the sequence of pubertal events, that is Theralke followed by Pubarke followed by Menarche, will be maintained in precocious puberty. Birth weight is important, as you have seen from the first case, that I have more propensity to develop a central precocious puberty because of the various reasons. Third, if there is any history of CNS trauma, irradiation, infection, you have to ask for the neurological dysfunction like headache, blurring of vision, symptoms which is associated with endocrine dysfunction, especially the hypothyroidism, that you have to specifically look for. Any exposure to exogenous steroid, you have to ask, especially seeing a case of isolated isolated precocious puberty. History of abdominal pain or swelling, generally it is seen in testicular CA or a mass which may secrete more and more of a testosterone or estrogen depending upon the gender. Family history of early puberty and short stages. We covered that maternal age of menarche contributes significantly to the onset of precocious puberty in the next generation. Physical examination, the growth chart is must. We must plot them on a growth chart. And one practical point which I've shown you on the girl's growth chart, that any deviation from the previous reading by 2 major percentile line is a classic example of early puberty. Must. If it is synchronous, then you can easily say, or the sequence is maintained, then it is a central precocious puberty. Sign hypothyroidism, see for the presence of cafe-au-lait spot, especially for the Mackin-Albright, which may present to you as an isolated or the only vaginal bleeding without anything, and they may have features of multiple fractures. So it's a very peculiar disorders, having cafe-au-lait spot with a history of osseous fibrous dysplasia and peripheral precocious puberty The girl may not have a breast development, as you can see from this particular case, but she has vaginal bleeding or menstruation. Palpate the abdomen for the masses. You have to look, especially if the child, especially the boy, if it's coming with the virilization, you have to look for the mass on the examination. So this is what has been taught to us as a Tanner staging, and as per the IAP growth monitoring guidelines, you must do the Tanner staging or SMR staging in a child who is more than 6 to 7 age, in boys and in girls and boys respectively. Most of the times it is not possible at times to undress them, especially in cases of females. So you can keep these photographs in your clinic, and the child himself or herself to think about the development of puberty, or maybe the mother would be a best guide. But do it, even if they are wrong, they would give you some kind of idea rather than having no idea whatsoever. Especially for the pediatrician, if they are coming to you for the vaccination at 5 years of age, you have to tell the mothers that please look for the breast bud. Now, the practical point is we call a precocious puberty when the breast development is at second stage, that is breast bud. But when mom tells you that her breast is developed, most of the times mother fails to develop, to diagnose a second stage. She always defines breast development as a breast stage development 3. So if mother is telling you that her breast is developed, it has just started developing, you have to take it with a pinch of salt. Probably you're not looking at a B2, but more of a B3. This is very important because you can't let it go telling that most of the girls are maturing early, then it is fine. You have to think and ask for the previous history. If she is less than 8, please investigate her right there. Similarly, for boys, you need a Prader's orchidometer to see the testicular volume. If not possible, at least he can pick what development of puberty, especially the testicular volume, that he can. Wise, basal LH, FSH, and estradiol is must in cases of females, and replace with testosterone in cases of boys. As I have previously, the basal LH is the most sensitive hormone. If you're not able to do the GNR stimulation, or it's not for you, then at least do a basal LH. Level of LH, which is more than 0.3, indicates a precocious puberty, or the pubertal sequence is already started. Please look for thyroid function and rule out the hypothyroidism, because hypothyroidism is one peculiar disorder which may present to you precocious as well as delayed puberty. If you're dealing with a premature adrenarche, then you can see for the adrenal surge by checking DHEAS, depending upon the case-to-case basis. The simple investigation would be a bone age, that is left hand and wrist till final terminal fingers, and any bone age which is more than 2 standard deviation, or maybe roughly you can say 2 years than the chronological age, indicates the pubertal onset. The gold standard for diagnosis of precocious puberty is a GNRH stimulation test. By using the aqueous function of GNRH analog, we generally give 10 to 20 microgram per kg of a stimulus. We check their LH, FSH during the baseline, and we check either 20, 40, 60 or 30, 60 minutes post the injection aqueous leupride. Normally, your FSH should be more than LH in puberty, and estradiol should be less than 10. And the subsequent rise of LH should be minimal. Whereas if you're seeing the pubertal case, the LH will be significantly risen as compared to FSH. As you've seen from the second case, the LH, which was 1.3, has gone up to almost 20 or 30. So a rise in LH by 2 to 3 times than the basal indicates that this is a positive GNRH stimulation test in the central precocious puberty. To that, if you're looking for a peripheral precocious puberty, suppose if you're dealing with a CAH, which is not classic, the LH and FSH will be more or less flat, but your peripheral hormones like testosterone will surge, which indicates that it is a peripheral precocious puberty. So GNRH test gives us a lot of information. If you don't have the access, I would suggest you at least check LH and FSH estradiol along with the bone age. That is the most important thing that one must do if the girl comes to you with the early onset of puberty. It is which we do technically just to see the ovaries and uterine size. If your uterus length is more than 4.5 or 5 centimeter, it indicates it's a pubertal onset uterus. Because generally during the pre-puberty, the length of uterus is less than 4.5 centimeter. You have to ask for endometrial thickness. If the endometrial thickness is more than 3.4 or 4 mm, it indicates that there is an imminent menstruation which will happen. Cervical ratio, if it is more than 1.2. So these are the technical parameters which we generally see. Now, the important point is the MRI of the pituitary gland. It should not be asked in every girl because, as I've covered previously, that 20% of the cases are idiopathic. So in girls, it is only warranted if the pubertal onset is before 6 years. Otherwise, do not do MRI pituitary in every girl. And this is more important because we are seeing more and more cases coming to us for the treatment, and they're coming with the MRI brain. So there is no need to do the MRI brain in girls. Boys, the chances of having an organic cause is more. So at any age, in cases of boys, you have to do the MRI of the pituitary gland of central precocious puberty, because the chances of diagnosing pituitary hematoma or any CNS dysfunction, maybe related secondary to SOL, will be more common in cases of boys as compared to girls. When we treat central precocious puberty, the first and foremost aim, or the prime aim, is the improvement of adult height. We don't get any fun in treating a girl who is already menstruating with a bone age of more than 12 and a half. So this is the most important thing, that we have to pick them up early before their bone age is 12. Second, we prevent a social or psychosocial problem related to isolation, school absenteeism during the menstrual phase or during the menstrual bleed for the next 3 to 4 days. And we want a complete suppression of gonadotropin secretion till there's a right time, that is 11 to 12 years of age. For the treatment of choice, we generally use the GnRH analog. It works on a competitive inhibition pathway. It leads to a down regulation of receptor function. We generally give in 3 monthly depot, either 11.25, or we give monthly depot of 3.75. It leads to inhibition of your HPG axis and leads to reduced estrogen secretion, and it holds the puberty at that particular point of time. So for example, suppose I'm treating a girl who is already B3. With the help of leupride injection, she being stabilized at B3 for a prolonged period of time. We tell the parents that not to anticipate that this drug doesn't regress the previous, whatever the changes are. So the breast development will be static at that point of time, but she will not experience a regression of or reduction in the size of breast development, which she already had. So it is kind of a pause button if you're watching a movie, and we continue to press that pause button till that point where we want her height to be absolutely in line with her height, and her mental age or a chronological age is sufficient enough to handle the pubertal changes and the menstrual hygiene. So this is the most important part which we consider in cases of treatment. The treatment until the progress of puberty is age appropriate. Now, when I say age appropriate, it is quite individualized. Some mothers feel that their daughter is quite ready at even 10 and a half. Some of the mothers, they feel that their daughter is still innocent by 12 or 13. So it is an individual decision when to stop the treatment. For best final height outcome, we generally treat them till their bone age is 12 to 12 and a half. If they're coming very late to us, maybe 13 years also we can consider. Even after discontinuation of the treatment, the reduction of puberty happens at a normal pace. So generally, once we stop the analog, by 6 to 12 months, we anticipate a normal puberty. The drug which we use is a medroxyprogesterone acetate. Those patients who are non-affording, they cannot afford the GnRH analog. In these cases, it leads to reduction in estrogen secretion. So it does two things. One, yes.
Dr. Digvijay, can you please pause? Dr. Digvijay? The admins need to do a better job. Dr. Digvijay, may you mute yourself, please? I don't think so. He knows that we are listening
Yeah,
to.
that's the thing.
Yeah. Dr. Saeed, may you please mute yourself? Thank you.
All right. So the second drug which we use in cases of precocious puberty, especially for the first couple of months, is medroxyprogesterone acetate. Two things. One, it inhibits the initial stimulatory effect of GnRH analog. As I said, GnRH works on competitive inhibition level. So there is an initial stimulation, the threshold for the pituitary to secrete the LH and FSH. So there is an initial stimulatory effect. And because of that, for the first 2 months, there are chances of minimal spotting, which is prevented with the help of medroxyprogesterone acetate. The dose is generally 10 to 20 milligram per day for first 2 months, because generally after 2 months, this initial stimulatory effect of GnRH analog or leupride weans off. It leads to suppression as well as progression of the puberty. Basically, it leads to a reduction in the estrogen secretion. However, there is no effect on of medroxyprogesterone acetate on skeletal maturation. It doesn't help you to reach the final adult height. With the help of leupride injection, if we get maybe another 2 years and if we prolong it before menstruation, they may gain almost 3 to 4 inches, which is quite significant. So 8 to 10 centimeter, it's quite significant if you are considering a height of 142 versus 150 centimeters. So again, highlighting the same, that you have to treat a precocious girl pretty early before she starts menstruating. Your treatment is effective. We generally monitor 3 to 6 monthly the as well as LH and FSH post injection, where generally the LH surge happens after 2 to 3 hours of injection. So if you are maintaining that LH between 3 to 4 or less than 3 to 4, that is the effective level. That means that the leupride is working optimally. So now I'm going to show you the last case. This is 8.5-year-old or 8.5-year-old girl presented from the periphery of the Maharashtra with the complaints of headache in occipital region. Very interesting one. Her CT scan was done, which was suggestive of a very large pituitary mass, which is compressing the adnexal structures. And they have been referred to Mumbai, having a neurosurgery and subsequent endocrine workup, because CT was suggestive of query pituitary mass, which has a compressing effect. On inquiry, she already had a menstrual bleed since last 2 to 3 months and breast development since last 6 months to 1 year. SMR staging, if you see carefully, she was B2. Axillary hair, there was no axillary hair, so A1. Pubertal hairs, there was just few hairs, so pubertal stage 1. And she has already started developing a menstruation, so she was M1. Now, what is peculiar again is her height and weight. She was very short. Her height was 93 centimeter and weight is 18.7. So she was quite short and underweight. And this is her clinical picture. On the side, you can see the breast development is minimum. There is no classic pubic hair. So she has just started. So this is P1. On the growth chart on the right hand side, you can see she was way too short for the normal height. And her bone age, which has been denoted by this blue star, is actually delayed. So this is not your bread and butter or a normal precocious puberty. This is something else, because in precocious puberty, anticipate an advanced bone age and advanced physical development, isn't it? So you would anticipate a girl to be a much taller and maybe more advanced in terms of bone age. But here is a girl who is pretty short, already started bleeding, no menstrual, the bleeding, but the breast development is maybe B2 to B3, not more than B3 for sure. So we are dealing with something else. Let's see her. So her LH was less than 0.1 So if you remember, any LH which is 0.3 is pubertal. So this is not pubertal. This is pre-pubertal. FSH is 3.1. Prolactin was high. The prolactin was 136 nanogram per ml. But it is not a significant, it's not very significant. That means it's not very in, you suspect a prolactinoma. Her estradiol is 40, so which is definitely. Her bone age was 3.6 years, so quite delayed. Her sonography you can see there is bulky ovaries on the bilateral side. If you check the volume on this particular slide, the volume is 68.6 centimeter cube. Now, just to give you an idea, a pre girl will have a volume of less than 1 to 2 cc, whereas this volume is 68 or 70. When the pubertal onset happens, you would generally anticipate maybe 3 to 4 centimeter cube. So what is this? Whether the primary lesion is in ovary or there is something in that pituitary gland. Let's see again. So we did MRI brain. MRI brain was done, and it was suggestive that it was as a large pituitary macroadenoma. You can see from the non-contrast film, and this is the contrast where you can see a significant supracellular extension with the pituitary stalk. So it has been reported as a large pituitary macroadenoma. Where exactly is the lesion? Lesion is in the pituitary gland, or whether the lesion is in the ovary, and what is causing this breast, no breast development or relatively less breast development with vaginal bleed. So any further investigation that you want to do, you can write it on the chat box. Yeah, has answered. Yes. So she has answered untreated long-standing hypothyroidism. So excellent. So we went asked for the same test, free T4 and TSH, and would be surprised that her TSH was even more than 1,000. The lab said that it was more than 500 because they could not report her TSH levels were actually 1183 to be precise. T4 was just 0.2. And her antibodies for thyroid, both the antibodies, that is TPO and TG antibodies, they were strongly. So this is nothing but untreated hypothyroidism leading to a precocious or isosexual precocious puberty, which is by the name of Van Wyck-Grumbach syndrome. The treatment is just simple. All you need to do is you have to give him thyroxine medication or a thyroxine tablet. Why this happens? It is an untreated, long-standing juvenile hypothyroidism with delayed bone age and isosexual precocious puberty or a peripheral precocious puberty. If you see the TSH, FSH, LH along with HCG, they are made up of two subunits. If you remember the biochemistry, their alpha unit, they share the same alpha unit, and their beta unit is different. It is because of this same alpha. This is the manifestation of Van Wyck-Grumbach syndrome is because of this. So what happens in Van Wyck-Grumbach? If you have prolonged and untreated hypothyroidism, your TSH will increase as a compensatory mechanism. So if you're not treating hypothyroidism, TSH will go from 5, 10, 100, 1,000. When it does that, the TSH, when it reaches to a significant level, the pituitary may to identify which is alpha and which is beta, and by which it secretes the FSH also. So because of that FSH, the ovaries get hyperstimulated and leads to a large bulky ovaries. So the to manifest sexual precocity is directly related to the TSH elevation. So higher the TSH, higher will be the severity of the precocity. So she will develop much earlier vaginal bleed as compared to the breast development. What does she need? Whether she needs neurosurgery? Definitely not. Whether she needs a leupride injection or a GnRH analog? Certainly not. All she needs is a thyroxine supplement or a thyroxine sodium tablet. So just a simple 25 paise per day would be an expense rather than undergoing a surgery. Because if at all, God undergo a neurosurgery, then they develop a condition called hypopituitary life. Now that MRI is the MRI which is being suggestive of pituitary adenoma or a macroadenoma is nothing but a thyrotropic hyperplasia. So imagine if your TSH is 10, 20, body will try to compensate. It will try to compensate further by secreting TSH. So that will lead to a thyrotropic hyperplasia, which get reported as a pituitary macroadenoma. So you have to be extremely careful reading the radiological report in such a scenario, and you have to see the case on an individual basis. So this is not a macro, this is actually a thyrotropic hyperplasia. 9 months after treating the girl, you can see the facial plethora is almost gone. She has gained 10.5 centimeter height centimeter. In fact, it is much more than what you could anticipate hormone therapy. So almost 1 centimeter, more than 1 centimeter per annum, and had her height standard deviation score had improved by plus 0.7. So there's a remarkable improvement with the help of thyroxine medication and the right. In what was the cause for large ovaries? This was unopposed FSH because of that alpha and beta subunits. And the pituitary macroadenoma, it's not actually an adenoma. This is simply thyrotropic hyperplasia. If you repeat this MRI after 1 year or 2 years, see this supracellular extension mass, and this will completely reversible. So you don't need anything, you don't need an operative treatment for this. So this is nothing but a hypothyroidism causing the peripheral precocious puberty. Other examples are McCann-Albright syndrome, which may present with cafe au lait spot, again a vaginal bleed. Autonomous ovarian cyst, we are seeing few cases of ovarian cyst. At times it may be a simple or it may be a complex cyst. Ovarian tumors, feminizing adrenocortical tumor are relatively rare. What is more common is exogenous estrogen. So you specifically have to ask for the estrogen cream application to the mother if she is using that estrogen cream herself. So learning points, hypothyroidism present to you with precocious as well as delayed puberty. Hypothyroidism presents with menstruation with or without breast development. The precocious puberty is generally associated with advanced bone age, but in case of hypothyroidism, you will have a classical delayed bone age. And important that it is common to have uncommon manifestation of a common disorder rather than a rare disorder. So what physician or a pediatrician should be careful about precocious puberty? Whenever you are seeing who is crossing 2 major centile line on an Indian growth chart, that either spurt in height or spurt in weight is important. If you're seeing an SGA children with sudden growth spurt, you have to be worried. Any breast nodule before 8 years of age. So remember 8 and 10, okay, for girls, their development before 8 years of age in boys and girls, then you have to refer them or do a workup. And if it is suggestive of precocious puberty, then please refer them to endocrinologists at the earliest before they have a significant compromised final height. So with this, I'll conclude. Thank you so much for your patient hearing. If questions, I'll be more than happy to answer. Thank you. All right. So Dr. Richa asked, anything to be done for isolated theral K before 8 years? Yes. So isolated theral K, there are 2 variants, Dr. Richa. First, if it is isolated theral K, you have to find out whether it is actually a manifestation of precocious puberty. If you are seeing an age group, the age group is more important. If you're seeing a child between 6 months to 4 years of age, then your benign theral K is more common, where your FSH will be predominant as compared to LH. So in that case, you don't have to do anything if your FSH is predominant. But if you're seeing a girl who is 6 years, 7 years, she has a breast development, that's not a benign theral K. You're looking at a precaution. So please get her LH, FSH done. If your baseline LH is more than 0.2 or 0.3, you have to treat her as a precocious puberty. Get her bone age also. And if you can report that bone age Do not rely on the radiologist's colleague who cannot give the accurate age. But if it is advanced by more than 1 year or 2 years, this is nothing but a precocious puberty. Even if it is unilateral, you have to treat it. In fact, 20 to 30% of the cases, this unilateral breast development rather than a bilateral breast development. So it is quite common. So that doesn't mean it is not a precocious puberty. See other questions. Yeah. Yes. So Dr. Rajaram Welling asked what treatment for central precocious puberty. I think I've covered that in my lecture, that treatment for central precocious puberty is a GnRH analog. We generally give the 3-depot preparation, that is injection leupride to the girl, or every 12 weekly. That is the first and primary treatment for precocious puberty. And for the initial 2 months, to cover the initial stimulatory effect of GnRH analog, we give medroxyprogesterone acetate, which is available in 10 mg or 20 mg tablet. Dr. Deepak asked, does it hereditary? Not really, not really. It's not a hereditary. You can say that, a maternal age of onset gives you some kind of idea. Her maternal age of menarche herself was maybe at 12 or 13 years. That is slightly early for that particular generation when you are seeing a mother of 30s and 40s. Mother is getting a menstruation maybe at 12 or 13. Then girl may get her cycles relatively as compared to a normal population. That's what it means. But it doesn't mean that it's a hereditary. Factor which I said for the precocious puberty is nutrition, obesity, and sudden weight gain span, which is what we are seeing, workload or huge cases of precocious puberty in last 2 to 3 years after the onset of COVID. Can we predict it early? Absolutely, yes. And that's what I mean. As I said, the point is, the SMR staging, you should not wait till that 10. I said to remember 2 figures, 8 and 10. But I would suggest that, 8 is most important than 10. If there is any breast development or breast stalk or the breast bud less than 8 years, then it is a classic case of precocious puberty. So if there is no way that we can prevent it. But if we diagnose them early, we can give them a full final adult height potential for sure. So that is most important. So identify them somewhere between B3, B4 before they start menstruating and refer them to the nearest endocrinologist. That is the take home point. And you can 100% give her the final adult potential. Likely complications for untreated cases and what can be done for children more than 13 years. Unfortunately, we can't do anything for the children. Again, I would say that it's not your chronological age, but it is your bone age, which gives us the idea whether the child will grow or no. But after 13 years, if you're talking about a girl, then in terms of height, we cannot do anything, unfortunately. And I'll just read her first question. Sorry, I missed that. Can we predict it early? Then, sir, many mothers ask us to stop milk to prevent this precocious puberty. What is your take? Excellent question. So that's from Dr. Kothari. That based on the fact that it is an endocrine disruptor, or most of us, they feel that the current milk has been in the cows or buffalo's milk, whichever we are drinking, is being injected oxytocin. So in India, we have that habit of boiling before we are using it. We don't consume the milk raw. And most of this, fortunately, their structure get denatured by 60 to 80 degrees Celsius. When we are boiling the milk, it is more than 100. So it will not lead to any precocious puberty, at least in India. Similar thing for milk as well as for the chicken or the dairy products, or you can see a meat product. So it is completely safe as long as we are not consuming it in raw manner. Only if it is consuming it in a raw manner, then you can say there is a theoretical chance of developing a precocious puberty. Any mother asks, just tell her to boil her milk and consume. Whether any correlation between precocious puberty and pollution food, that's what I had answered. Secondly, there are certain endocrine disruptors, especially in the DDT and your pesticide. So what they do is they lead to a hypomethylation process, which forms as an endocrine disruptor, and they stimulate the GnRH stimulator. So that's a theoretical pathway, but how much it is truly significant, that we really don't know as of now. And maybe these are the things I don't think that is under our control. But yes, I mean, this is what has been postulated. Those endocrine disruptors especially has a steroid ring, and they lead to a hypomethylation. So yeah, role of treatment after starting menses in precocious puberty. As I've said, in the second case, only for psychological reason, so that she gets to that age where she can handle the pubertal or the menstrual hygiene properly, maybe at 11, 12. So that is the only role where we are treating the after the menstrual. But we have to treat anyways. If one of the sibling is having precocious, what are the chances of sibling getting it? As good as normal. Okay, there's no higher risk if sibling has it, unless you're looking for a dizygotic twin. We may have kisspeptin receptor mutation. I think I've answered most of the questions. One question from Dr. Deval was likely complication for untreated cases. Really, no unless you take as a long-term effect of a short stature. So precocious puberty is a double-edged sword, where to begin appear very tall, but their final height is compromised. That you can say it's not a complication, but it's the outcome. The child to begin with, it's pretty tall, so but if you're not treating them on a right point of time, then they end up being short, maybe 130, 140 centimeters, depending upon the onset and their existing bone age. Isolated adrenal case, especially axillary hair, doesn't need any treatment unless it is having an underlying significant cause. Dr. Ganesh Vadgaonkar, how long should we give the GnRH? So I've answered that partially. So GnRH to be continued till the bone age is 12, or the child is able to understand about the menstrual hygiene and would be able to handle it when they go to school. So roughly at around 11 to 11.5 age of chronological age minimum, bone age of 12, 12.5. Can soya products cause precocious puberty? Less likely. Thank you so much. Now, I think I'll invite Dr. Shruti talk. That's when to think of doing a genetic evaluation in cases of disorder, especially in pediatric age.
Hello, Dr. Prashant. Thank you for the wonderful session and the kind introduction. And thank you, SRCC Hospital, for this lovely platform to interact with all the enthusiastic colleagues out here today. So as Dr. Prashant said, in today's session, we will try and see some basics as to when and why should we be suspecting genetics in the first place. Please, can someone confirm if my screen is visible so that I can start with the talk?
Yes, sir, visible.
It is visible. Thank you.
I'm going to invest the next 5 minutes in first trying to touch upon rare disorders and its implication in today's practice, because rare disorders and genetic disorders are nearly considered to be synonymous, given the fact that 80% of the rare diseases are due to a genetic etiology. We were often taught during our med school that when you hear hooves, think of horses and not zebras, implying that a physician should first consider common etiologies and maybe not really pay attention to the uncommon ones. While this dictum is important to be remembered, I think what has happened in the last 40 years since this adage had first started is that we have realized that while rare may not be the top differential, rare disorders do exist. And in the next 30 minutes, we'll in fact see the paradox of how rare is actually many. This was a 36-year-old lady who presented to our clinic with gait ataxia, which was progressive in onset. She had family history of other members being affected similarly, progressive complaints, early death. You can see that even her features started at an age much younger than her father. She had tremors, and her MRI showed spinocerebellar atrophy. Well, in such a scenario, we do suspect a disorder called a spinocerebellar ataxia, and rightly so, the correct genetic test helped us to pick it up. Now, why did I put this case first, where we often see that 80% of the rare disorders will actually come in the childhood period? But it doesn't mean that genetic disorders cannot present in adulthood. In fact, genetic disorders can present anytime from the womb to the tomb. The next case is that of a little, it's of a schoolboy, 7-year-old. He came with this left tongue mass. It was diagnosed elsewhere by a pathologist as a mucosal neuroma. Referred to the pediatric surgeon, and as we know that mucosal neuroma can be sometimes one of the parts of a constellation, of a cancer constellation, what we call as meant-to-be syndrome. Meant-to-be syndromes can have multiple other associated cancers, some of them being these very aggressive thyroid cancers. So now the thought process by the pediatric surgeon was, if I'm going to remove the tongue mass and in the same anesthesia setting, I can remove out the thyroid if need be, if this is indeed meant-to-be syndrome. With this thought process, the patient actually was referred to genetics to rule out meant-to-be syndrome. However, as it often happens, that it is the beauty lies in the details, and sometimes simple clinical signs can help us to arrive at a correct diagnosis. On examining this child, he had a lot of caphioles, these brown-colored spots, which you can see scattered all across the body. Incidentally, even the mother had a very large caphiole, and her mother had expired of ovarian cancer. So suddenly we get thinking whether this could be a disorder which is presenting in 3 generations, variably associated with some neurocutaneous markers, some cancers, and immediately the thought of neurofibromatosis as a diagnosis crosses our mind. And we know that the schwannoma, the biopsy picture of a neurofibroma related schwannomatosis can mimic mucosal neuroma. And that is precisely when we did a repeat biopsy. And the biopsy actually showed plexiform neurofibromas. This was not mucosal neuroma. And genetic tests proved this to be neurofibromatosis. Now, my reason to select this case was this patient did not walk to a geneticist first. This patient first went to the pediatric surgeon, was screened by the pathologist, and quite akin to this condition, almost all genetic disorders will present to all the physicians present in the audience today, whether we are general practitioners, specialists, endocrinologists, dermatologists, pediatricians. These are the plethora of cases, some of the cases that we have seen in the last few months. So a case of epidermolysis bullosa, genetic disorder, presenting first to the dermatologist, failure to thrive with intellectual disability due to 13q deletion, presenting to the pediatrician first, extreme obesity presenting to the endocrinologist, whereas it was actually Prader-Willi syndrome. This girl actually presented with just strabismus and myopia, seemingly innocuous findings, but she actually had DiGeorge syndrome. She had underlying developmental delay, facial dysmorphisms, and so on. So the next point which I wish to highlight, first one was that rare disorders can present at any age, and rare disorders can present to any specialist. And having understood these 2 points, we need to understand that India is not an exception to rare diseases. Gone are the times when communicable diseases were top on the list of features bothering us. The preceding lecture, precocious puberty, and a lot of other things. It is the non-communicable disorders which are now coming to the forefront in our practice. And genetics is no exception. In fact, India with South Asia is quite like the undeclared capital of genetic disorders. And this is because of the huge population, the universality of marriage in this part of the world, the practice of marrying within the same communities, which is called as endogamy. And of course, the practice of marrying within cousins or closely related relatives, which is called as consanguinity. And so what I wish to highlight over here, there's soon going to be an era of population genomics where we are going to understand specific communities are predisposed to specific genetic disorders because of the idea of inbreeding for centuries. So having realized that rare disorders can present to any specialist, they can present at any age, they are common in India. In fact, India burdens 1/4 of the global burden of rare disorders. We understand that rare is many. And with this brief introduction, with this brief prelude, I would like to now, in the next 20 minutes, take you through some very, very simple handles, case-related scenarios to help us understand when and why should a clinician think in terms of genetics. So there is an easy aid memoir, which goes by the name of Family Genes. In the presence of family history, and of course, I'm going to corroborate each of these with case studies, family history, group of congenital anomalies, exceptional presentation of a relatively common clinical complaint, neurodevelopmental delay or regression, extreme pathology, surprising lab values. These are some of the easy indicators and the low-hanging fruits that can help us to pick up genetics early in our busy and inundated OPDs. So this was a young boy who actually presented with short stature and rickets. And this child was actually being treated for rickets for years. The penny dropped when his younger sibling was brought clinical features. And on seeing and evaluating the child, it was evident it was on the X-ray. This child had plaques totally. And we suspected a condition called as mucopolysaccharidosis or Morquio disease. And indeed, it was a case of MPS type 4A. However, it was a diagnosis which was established at a cost of recurrence in the family, and especially when there is a treatment available for this disease, a specific enzyme replacement therapy. It really hurts to see a diagnosis being made and the delay causing such a lot of negative impact on the family. Some other scenarios, we see families having breast cancers, short stature, with other members having Duchenne dystrophy, previous child with intellectual disability, or a previous fetus being terminated due to multiple anomalies, blindness, deafness, and so on. But what we need to remember is that the absence of a family history should not be a reason to not suspect genetic disorders. In fact, nearly 80% of the genetic disorders will not have a clear-cut family history at the outset. So, which is why we need to keep in mind the other red flags too. So next one is group of congenital anomalies. As clinicians, we will often be challenged when we see a newborn being born with various birth defects, major anomalies and minor anomalies. Often you may not be able to arrive at the definite diagnosis on looking at the cluster of anomalies in the first go. That is perfectly fine. However, suspecting a genetic condition in time on looking at these group of anomalies is very important. So this was a newborn who presented with club feet, cleft palate, microretrognathia, and respiratory insufficiency. And this can really, the club feet can be due to, this constellation can be due to a range of clinical differentials, right from skeletal dysplasias to myopathies to aneuploidies. However, if you, excuse me. Yeah, I'm sorry. If you look at this X-ray, so this child had respiratory insufficiency. And when we look at the X-rays carefully, there are no scapular shadows which are visible. The pubic shadow is also not visible. And this, along with for someone who is into skeletal dysplasias, this is very typical of a bone-related genetic disorder called as campomelic dysplasia. Now, why was it important for us to make this diagnosis? Well, because this is a condition which is not a very good prognosis, is not associated with a very good prognosis. And arriving at a confirmed diagnosis while the child was in the ICU was empowering for the physician as well as the parents to take some tough decisions about the aggressiveness of the treatment that they had to follow. So we see how timely genomics can help to help to take clinical decisions and guide the family even in the absence of a definitive cure. While I'm sure major malformations would not be missed, what we need to keep in mind that we should not even ignore the minor malformations. Because in the presence of more than 2 minor anomalies, there is a good chance that there may be an underlying major malformation. And all of these act like pieces of the jigsaw. Each physical sign, each detail about the pedigree can take us closer to the genetic diagnosis. This is just another example of antenatally detected cluster of group of anomalies, and it was a case of a double copy number variant. This child had, this fetus had trisomy 6 as well as monosomy 7. When we talk about birth anomalies or birth defects, in a recent study, it was found that while we could find the etiology of just 20% of the birth defects in their study, more than 99% of this group where the etiology was found was due to an underlying genetic cause, basically. So we see how we should keep an early sensitization and early a low threshold to suspect an underlying syndrome when you see a cluster of congenital anomalies. Now we come to extreme manifestation of common conditions. So we see a child getting fracture after a road traffic accident. That's a common condition. But if you see a child getting a fracture after being pushed by the sibling, and that when it is clubbed by unusual fracture sites, blue sclera, we know we are thinking in terms of osteogenesis imperfecta. And why is it important? Because timely bisphosphonates can help us to reduce the fracture frequency. Of course, there are many such examples. Extreme myopia at a very early age, extreme obesity lesser than 5 years of age, extreme short stature, extremely early puberty, precocious puberty also. The very interesting lecture that preceded Dr. Patil would agree that there is a fair chunk of genetic contribution in precocious puberty too. So we need to keep in mind all these extreme outlier clinical features in our practice. Extreme tall stature could be Marfan syndrome. Extremely short stature in a girl child, you need to think of Turner syndrome. Of course, these are just the tip of the icebergs and the most common differentials that we are talking about. Now we come to the N part of the mnemonic. So we have done with family genes, F for family history, G for group of anomalies, E is extreme manifestation, N is neurodevelopmental delay or neurodevelopmental regression. I'm sure we would agree that as compared to what neurology practice was 20 years back, a lot has revolutionized since the advent of these new age genetic tools and precision medicine. A lot of cryptogenic seizures, a lot of things which were labeled as cerebral palsy, myopathy of unknown cause, now have an answer and a precise genetic diagnosis. So delayed development, neuroregression, of course, stubborn seizures, atypical seizures, 25% of the cerebral palsy. Mind you, even in those cases where there is a clear-cut asphyxia history, 25% of a recent cohort published by Chopra et al., had an underlying genetic etiology. In those cases where there was no clear etiology, the genetic contribution was even higher, going to nearly 30 to 35%. So if you see siblings with cerebral palsy, atypical MRI, absence of perinatal history, global developmental delay, neuroregression, these are red flags to consider an alternative diagnosis early. Hypotonia, neuroregression, ataxia, encephalopathy, head circumference abnormalities, autism. So we have recently nearly just about concluded a 150 autism study and its genetics at SRCC. The results are expected. This is a case of this is just to contrast how two children with the same diagnosis but flung across continents. Can I please request the person who's talking to please mute himself? The admin, can I please request you to mute everyone? And I think I'll just if every. So this was a 9-year-old male child, and he had an uneventful birth, global developmental delay, seizures, encephalopathy, and dystonia. Despite red flags, that this child had a normal birth history, this child was labeled as cerebral palsy at 5 months of age. It was at 2 years when an MRI was done for repeated seizures that glutaric acidemia was suspected and confirmed. However, by that time we had missed the bus because the neuro damage was already done, and someone had counseled them there's no use pursuing treatment. Although even at 2 years, had we started the definitive treatment, the child wouldn't have been this neuro damaged. Now contrast this with another child, again having the same disorder, glutaric acidemia. However, she was on protein restricted diet and special medical food right since her birth, and today she is studying in 4th grade, enjoys a normal life, and is neuronormal. So I think if at the end of these 30 minutes we can just take one key message that early diagnosis matters, it would really help to change a lot of lives. We come to the E part of the mnemonic, that's extreme pathology. So this was another child who was 4-year-old, had oil dripping from his stools since the first month of life, extreme failure to thrive in recurrent pneumonias. Now, this is an extreme pathology. It's not a common presentation. We thought in terms of cystic fibrosis because cystic fibrosis does have, pancreatic insufficiency in 2/3 of the babies at birth, and that can give rise to steatorrhea and or frank oil dripping through the stools. Now, why was diagnosing this important? Because timely diagnosis of cystic fibrosis helped us to initiate timely pulmonary toileting, prophylactic antibiotics, pancreatic enzyme replacement. In fact, now there are CFTR gene modulator drugs. All of these can really change the child's quality of life. This child has been following up with us for the last 2 years with no repeated pneumonias. The child has gained height, gained weight, is doing well scholastically. So really the impact of a timely diagnosis cannot be overemphasized. Last part of the mnemonic is surprising lab results. So this was again another child with rickets. I started my talk with the child with rickets. And again, this child was just being treated with calcium and vitamin D and, with really no response. Height was faltering day by day. He had seen all the specialists. And finally, when they came to us, when we checked, this child actually had paradoxically sky-high levels of vitamin D, whereas what you normally expect in a child with nutritional rickets, and this was even at the outset before the vitamin D treatment, that the vitamin D levels were elevated. So this was actually a problem in the pathway where vitamin D was not getting converted to its active form because of the deficiency of this enzyme, what we call as vitamin D deficient vitamin D dependent resistant rickets type 1A. And really what you need over here is the active form of vitamin D or rocaltrol that needs to be given. And we started the child on therapy and he's doing wonderfully since then. So how analysis of the lab reports can help us to suspect a genetic condition in time. It could be a child having, often we have seen or got calls from an astute lab physician calling us that the blood is looking lipemic, although you've not sent it for triglycerides. Should we be looking at it? And I remember during my learning days at KEM Hospital, often we had diagnosed 1 or 2 storage disorders in this way by picking up the lab clues early, and looking 360 degree. So with that, I come to the last fraction of my talk as to why should we be making an attempt to diagnose these cases early. I have been, alluding to this in the rest of my session that these rare disorders really, because we are so used to thinking in terms of horses when we listen to hoofbeats, that we fail to look at the stripes in the crowd. We fail to identify the zebras within the horses. We fail to make the rare disease diagnosis. Although rare is many, it is estimated that 1 in 10 of us will live with a rare disorder at some point in our life. It is estimated that each patient with rare disease on an average takes 7 to 8 years to get a diagnosis. In this time, he meets 8 physicians, of which an average includes 4 super specialists, and still at the end of it, nearly half of them are misdiagnosed. So why should we be sensitizing ourselves towards this not so rare disorders is to limit and to truncate these diagnostic journeys. In our own paper, which we published some years back in 2015, we studied the time profile of 119 cases of lysosomal storage disorders, where you see that the delay in diagnosis was because of the delayed referral. After referring, the median time interval for diagnosis was less than 1 month. So I think we often come across this argument from friends and colleagues, genetics is so expensive. I know it takes so much of time. There was a study which is published and shows that timely genetic test, quite contrary to our thought processes, actually saves money if it is done in the right manner, right test, right indication. Genetic tests, as per the study, can actually save $19,000 per family and 6 to 7 years of chasing a diagnosis per family. Of course, the disclaimer in bold that this needs to be done with specialists in neurometabolic spectrum and in genetic disorders. So this is just to say that timely diagnosis actually ends up saving on a lot of unnecessary tests and unnecessary hassle for the patient. This was a child who presented to us at 8 years with autism and delayed development. And the reason was why they saw a geneticist was they were planning another baby. Now, when I started taking the history, the first symptoms were noted at 6 months of delayed development. However, this patient came to me at 8 years of age. And on looking at the papers, what do I find? This child actually was admitted thrice in the ICU. All the 3 times it was due to episodes of recurrent encephalopathy. The treating pediatrician had very rightly thought in terms of inborn errors of metabolism, and this child had elevated ammonia, high anion gap acidosis, but every time he would get okay with symptomatic treatment and get sent back home. Inborn errors of metabolism are genetic disorders where certain housekeeping enzymes are deficient in the body, and because of which proximal to the block, there is an accumulation of toxic metabolites. Now, if this block is treated with diet therapy, with medications, the symptoms can get treated. And I didn't know whether I should feel happy or I should feel sad when we made the diagnosis within 21 days of the patient being referred to us. Our suspicion was right. This was a case of chronic intermittent type of maple syrup urine disease. Because the enzyme deficient was not very severe, this child did not have the severe neonatal encephalopathy presentation, but rather had this intermittent episodes of encephalopathy and a background of autism. Now, had this child got diagnosed in the first episode, probably the neuronal circuits wouldn't have to take the toxin load for all these years. The synapses, the circuits would be better wired. Probably he wouldn't be having autism and ADHD today. And we can say this with confidence because within 6 months of giving this child the targeted medical food, carnitine, specific supplements, the mother reported that the child was more than 25% better. His hyperactivity had reduced, his cognitive abilities had improved. Of course, their main take-home was they wanted to plan another child, which they can now do because they have a confirmed diagnosis. But imagine the pangs of regret to think that this child who's today autistic and ADHD could have been a neuronormal child and living a normal life had we suspected this diagnosis in time. And this is where I want to stress that not all genetic treatments cost 100 lakhs or 17 crores. A lot of these are easily treatable by inexpensive medications, vitamin supplements, dietary powders. Now these special powders are being, produced in India. There are more than 110 treatable causes of intellectual disability today. And as I am talking, I'm sure this number has gone up from 110 to 120. That is the pace at which newer therapies are being ushered into the market. Of course, this is an era of precision medicine. So maybe 2 decades back, when we chose anti-epileptics, it was like a toss of a coin. Acts, you continue, does not act, you change. It was more of trial and error. But today, you integrate the neuroradiology, the EEG, the patient history, family history, club it with the right genomics. You know this is the gene that is defective, and so this is the drug that I need to give. It is a time where futuristic therapies are modulating the drugs is soon going to be, it's already in practice where we are, giving precise therapies based on the molecular diagnosis. Of course, last but not the least, there's a lot of buzz and excitement about CRISPR-Cas9 technology. This is nothing but genetic scissors where you can cut and edit the gene, put a gene of your liking, a healthy gene, remove out the faulty mutation. And exciting and sci-fi, though this sounds, there are a lot of ethical and legal concerns that surround CRISPR-Cas9 technology. And while gene therapy is available for a fair share of diseases now, it's still going to be quite some time before this part of treatable genetics becomes meaningful and accessible to the common man. Of course, why should we make a diagnosis? It's again because, as I said in the previous case, if you want to have a normal child after a suspected genetic disorder, just a clinical diagnosis is not enough. You need a precise molecular diagnosis. So like this child, you can see and say, okay, it was a colloidal baby, but colloidal baby or Mendelian disorders of cornification can be due to more than 54 genes. You need to have the precise molecular fingerprint. Quite like Sherlock Holmes' obsession with the fingerprint of the murderer, we geneticists are obsessed with the molecular fingerprint, that is the mutation. And once you have the mutation for a given genetic disease in the family member, in the next child, being able to predict whether the fetus has it or not is really very easy for geneticists. All we do is we would check the amniocentesis, remove out the fetal cells, see if the fetal cells carry the same mutation that the patient is carrying. If yes, we inform the family to take a decision, and if no, they can comfortably go ahead. For those families who do not wish to go through this process of conceiving and then aborting if it is abnormal, either because of medical reasons or religious reasons, where termination of pregnancy is not acceptable, we now have an attractive option, which is a pre-implantation genetic diagnosis. It essentially includes taking the sperm and the egg forming an embryo and testing these embryo in vitro. Only those embryos which are healthy and not carrying the harmful mutation are then implanted into the mother's womb. So, but all this can happen if we suspect early, if we diagnose early, and if we diagnose correctly and precisely. Many a times, even though the genetic suspicion is very strong, there are limitations to modern day genomics where every time you may not be able to hit the bullseye. And if you do not have a precise diagnosis, you cannot offer prenatal diagnosis to for the next pregnancy. Of course, in such cases, it's always prudent to connect and collaborate with your genetic colleagues, because many a times the test platform that could have been used may be outdated, the data could have been outdated, the phenotype could have been incomplete, and sometimes on rejoining the dots, the diagnosis may become clear. So this is to summarize why the effort. I've made it clear that for recurrence prevention, you need to know what was the diagnosis in the previous baby. This is another advantage. For example, you have a patient with breast cancer who's got detected with BRCA2 mutation. She has sisters, she has a mother, she has a brother, and they all wish to know whether they could be at risk of BRCA2 related cancers. So genetic medicine is quite akin to family medicine, where you look 360 degree. It's not about a blinkered view of just the patient. You could be having a child with Duchenne muscular dystrophy, where the mother who's transmitted the gene will not get symptoms of Duchenne, but she's at a risk of dilated cardiomyopathy after 40 years of age. So you see how genetics can really help us to alert these other family members about their risk. I've already spoken about how treatable genetics is no longer a thing of the past. In fact, we can have an entire day CME on the genetic disorders that are now treatable. And I think if nothing else worries us, this is something which will surely worry us. I rightly read a post few days back on the social media that you look at the patient medico-legally first, then legally, and then medically. It would be interesting to know that delayed suspicion due to failure to refer by the primary physician was the second most common cause of medico-legal litigation in one of the studies which analyzed the causes of medico-legal suing in ENT practice. So if we see a case which is beyond our domain of expertise and training, beyond the risks, beyond the benefits which I have alluded to, it is our duty to kindly refer so that this family gets the right benefits of a timely diagnosis. Of course, it's important to prevent complications. So you may diagnose a case with Turner syndrome and wonder what's the big deal that you have picked it up. But Turner syndrome is associated with aortic dissections, hypothyroidism, celiac disease, hypertension, and a plethora of findings. While I cannot treat Turner syndrome, I can treat all these offshoots of Turner syndrome, and limiting the comorbidities can help the family to get a better quality of life. Of course, it helps the family to save money and time to get a timely diagnosis eventually, and sometimes just for prognostication and closure. We all love Harry Potter, and he had an invisibility cloak, which made him disappear time and again. And I think genetic disorders also would surely be having this Harry's cloak. They will never walk into the OPD telling that I'm a genetic disorder. We really need to keep our radar on high alert. And I love this last slide, a poem contributed by a very dear colleague, Dr. Pragna Ranganath. I think it sums my talk and the essence of what I wish to convey. If you have a patient with muscle weakness or seizure, send him to a neurologist and a geneticist for good measure. If you have a patient with an enlarged liver or spleen, he could be having an acquired problem or a defect in some gene. If you have a patient with a defect in the heart, it may be isolated, or of a syndrome, it could be some part. If you have a patient who's not thriving well or is short, he may have skeletal dysplasia or a syndrome of some sort. Keep a genetic etiology always in mind. not because I'm saying. But if the case especially is confounding you, it is very likely to be of a genetic in kind. Thank you so much for your patient listening. I would be open to questions.
Ma'am, Dr. Jumani, can I ask one question?
Yes, sir. Good evening, sir.
Yeah. So hyperhomocysteine, like, how do we suspect at the early age when the child has got a hypermyopia, what all the things we should look into it?
So, yeah, thank you for the question, sir. So usually, if there is high myopia, if that is my lead handle, even isolated high myopia can be genetic in etiology. But what you are speaking is a syndromic high myopia. Homocystinuria would often be associated with intellectual deficits, hypercoagulopathy, along with high myopia lens dislocation. So if you see a syndromic complex, of course, of the multiple causes of raised myopia when associated with the syndrome, homocystinuria is one of them. So tall stature, intellectual deficits, these would be the red flags when you start suspecting. Of course, a close differential would be Marfan's. Often we see in clinical practice is not very easy to say whether it's dislocated superolateral or inferolateral always. It could just be a loose lens sometimes. And so you need to really assess the child in a stepwise manner, look for the various physical clues of the associated differentials which form your syndrome list, and then maybe take it ahead, sir.
Okay. Ma'am, if the parents are taking a lot of psychiatric medicines, what are the chances, if they are taking since long, the whole family, the from the boy side, girl side, and they get married, and then unfortunately, what are the outcome? Like, how do we prevent the children also to get this possibility?
So in genetics, there are two types of broad disorders, monogenic and polygenic. Monogenic are conditions that I discussed about. But other than that, there are lots of conditions like asthma, depression, diabetes, which are polygenic in nature, psoriasis, HLA-B27, angst. Now, polygenic conditions cannot be diagnosed by the current platform, and they cannot be necessarily prevented because polygenic conditions are multifactorial. They have a gene environment correlation, and you cannot predict nor can you prevent because, of course, lifestyle modifications and the environment modifications is all that you can say. But otherwise, there really isn't much that genetic science can, help them in those ways.
Thank you.
25% of X-linked recessive carriers of Duchenne muscular dystrophy, as per one study, can be having other features of dilated cardiomyopathy. This was just one example. If there is a child with ataxia telangiectasia, we say that the parents are carriers. Parents are supposed to be normal. But the mother who's carrying the heterozygous variant for ataxia telangiectasia is at a much higher risk for breast cancer. So these are just examples of what I was trying to show, how sometimes a genetic diagnosis percolates to the rest of the family and doesn't remain restricted to just the patient. Okay, I think we are done with the questions. If there is the admin there around? Okay.
Yes, ma'am.
Yeah. Pyruvate carboxylase. Someone has asked about whole genome sequencing. Okay. Okay, so I'm going to try and explain this. We have in ascending order, whole genome is something which I would say in very simple analogies like the Brahmastra of genetics today. It's like a big missile which we think 10 times before we shoot. Of course, exome sequencing, microarrays, MLPAs, These are tests which are more popular, even in terms of a busy genetic OPD. So when we talk of a gene has an active part called as the exon and a non-active part called as the intron. So exome sequencing looks at the exons of the gene. Clinical exome will just look at the exons of 5,000 to 8,000 genes, while whole exome sequencing will look at the exons of all the genes together. Whole genome sequencing looks at the entire genome, not just the exons, but the entire genome. I would like to add a word of caution here. In the era of genomics, we are often tempted to believe that when the moment we see a child with suspected genetics, let's just quickly send the genetic test. We don't need to do the other tests. So if you have a child with seizure, we've often seen, unfortunately, patients being incompletely worked up, but genetics being sent. Phenotype is as or maybe more important in today's era, because with the right phenotypic and the clinical clues, it is with that the genetic correlation can be made by the lab and you will get a right report. It's like any other laboratory medicine, that phenotype would be very important in these cases. So whole genome sequencing essentially looks at the entire genome, sir, but it costs very exorbitant, and there are a lot of chances of junk findings and uncertain findings if it is not correlated with the complete phenotype and the phenotype sent is incomplete. Yeah. Okay. Thank you for your patient listening, and I will take your leave. Thank you so much. The admin, can I take your leave? Okay.
And it's easier because he doesn't have to run, he can play shots, and he's played them really well. Another 6, heavily on its way. It's It's just something to track a little because I think he wanted to go full ideally, and he just got caught up except for sex. So he's got to get it straight and full. He missed his leg. Six. We generally don't see perfect timing. Everyone is happy, and then come the celebrations. Wonderful time to remember the what an investment that's been such a young man that hold on so that young shooter could get to play cricket. Now that investment is proved so profitable that we've produced the youngest player to score a double 100 in one internationals. It's a good time for young players. Just after Ishan Kitchen scored a double. Now Shuman Gill scored a double. One's 23, the other's 24. 19 of this over. Couple hundreds of the eyes. First one. Was it Wire? 200. Then Seva, Rohit Sharma. Now these two young men. And then being on the rally, shows you the time. Glycolic, late 2010. With a ball shot and produced a single. 21 came over. 239% of it. Here's something more specific. You need Linda putting on a batting. So
सकाळीपासून संध्याकाळीपर्यंत काय म्हणते ओके